So to continue our discussion, the treatment consideration in this case include switching the HARTs, and switching has been extensively evaluated in their effect on reversing the body composition as well as the metabolic abnormalities. So using less toxic medication than stavudines or geodovine is recommended at all cases, and many would require collaboration between HIV specialists, endocrinologists, as well as a pharmacist in general. So in the lipoatrophy, it has shown efficiency for increasing the subcutaneous fat in the non-HIV lipoatrophies, also using mixed results for HIV-infected patients in clinical trials for about 48 weeks has showed improvement in the limb circumference, the skin fold thickness, but also changes in the fat was not receptive to these patients. So for statins, in a small randomized controlled trial, it has, for patients treated with bravastatins for about 16 weeks, showed increase in the limb fat compared to the placebo cases. While for the uridine, many can prevent or even reverse the mitochondrial toxicity in patients who are treated with stavudine. And for surgery, having facial filters and reconstruction by plastic surgeon had improvement in the key field with decreased anxiety and depression. Also, autologous fat transplantation has been successful or successfully used as a treatment method. Also, for the lipohypertrophy, which is very difficult to treat, it included having lifestyle intervention with only modest improvement that have been seen with the resistant training and aerobic exercise. Also, metformin has decreased the visceral fat in HIV-infected patients, as well as variable results have been documented. So metformin plus exercise appears to have used treating the lipohypertrophy. Also for the GH axis, the HIV-infected patient with body composition changes has also shown reduced Hg mean doses ambulated and may be correlated with central fat accumulation. And for surgery, liposuctions can be successful, in particular for the dorsofacial fat bad accumulation, and reoccurrence can be a problem in these cases, therefore should be anticipated. So for the dyslipidemias, it is recommended to use CCS lipid guidelines, and the preferred agent is statin in this case. But also we need to consider the risk of the pharmacological interactions, such as bravastatins and fluorostatins, which are safe with the ritonavir, while simvastatin and lovastatins are contraindicated in these cases. Also, for diabetes and insulin resistance, we should continue to use the CDA guidelines, and the insulin sensitizers may have a role. Also, reports have shown that HbA1c can be inappropriately low in these patients with HIV therapy, thereby underestimated glycemia. So this can be due to chronic low level of hemolytic state from the viral infection or even from the HART medication. So the parathyroid gland have an overall regulatory role with the actions as a thermostat in the systematic calcium homeostasis to ensure a tight regulation of the serum calcium concentration and the appropriate skeletal mineralization. So the parathyroid hormone can affect the calcium, phosphorus, and vitamin D metabolism by removing calcium from the bones to raise the serum level, and as well promoting the hydroxylation of vitamin D to its active form. So calcitonin, in contrast to the parathyroid hormone, decreases the serum calcium level and it is secreted by the thyroid gland. So the body secretes parathyroid hormone in response to hypocalcemia or hypomagnesemia. And the hormone will then stimulate osteoclasts to increase the bone resorption. So parathyroid hormone also stimulates adenyl cyclase to increase the renal tubular calcium resorption and the phosphate excretion. So parathyroid hormone works with vitamin D to regulate the total body calcium by activating the conversion of the inactive vitamin D to the active form. And this active form then stimulates calcium and phosphate absorption from the GIT. So calcitonin, in contrast to the parathyroid hormone, will decrease the serum calcium level and is secreted by the thyroid gland. Also, fibroblast growth factor is a hormone that regulates the mineral and vitamin D metabolism. So, research on the effect of virus genes and hormones in the bone homeostasis is still ongoing to have the best detection for their effect or role in general. So, hypoparathyroidism and hypocalcemia. First of all, hypoparathyroidism results from a deficiency of the parathyroid hormone from a biologically ineffective hormone. So damage or accidental removal of the gland or impaired skeletal or renal response can also lead to this condition. And in the hereditary form, parathyroid glands are either absent or even not functioning properly, and symptoms appear before the age of 10. So other causes can include magnesium deficiency or neonatal immaturity. And if untreated, then hypoparathyroidism, retardation, dysmorphism can also result. So cancer response and in the hypoparathyroidism are abnormal, suggesting that parathyroid hormone is required to maintain normal trabecular structure. So hypoparathyroidism with hypocalcemia is one of the most common results of damage to the parathyroid gland during surgery. And in fact, it may be diagnosed during workup for hypocalcemia. So vitamin D level can also be deficient in this condition, and intraoperative parathyroid hormone levels are used widely during the parathyroidectomy as an indicator of parathyroid gland function. Also, vitamin D supplementation after surgery may be given to anticipate any decreased parathyroid gland function and also to avoid the symptomatic hypocalcemia. So hypoparathyroidism is considered as a chronic condition that requires lifelong treatment with large doses of calcium and vitamin D supplementation. And episodes of tetany are treated with calcium that is given intravenously to provide a quick relief of symptoms. So controlled release of the physiological concentration of the parathyroid hormone can be achieved using surgically implanted controlled release delivery system. And for the intervention objective, we should normalize the serum and the urinary level of calcium, phosphorus, and vitamin D. Also preventing long-term complications such as cataract, pernicious anemia, and Parkinson's disease with bone disease. Also preventing mental retardation or malformed teeth in affected children, as well as decreasing the symptoms of tetany and improving the overall health status for these patients. So for food and nutrition, using a high calcium diet with dairy products, including nuts, salmon, peanut butter, broccoli, and other green leafy vegetables is recommended. Also, if tolerated, having lactose should be included in the diet for better absorption of calcium, as well as oral supplement that is high in calcium should be used, such as calcium carbonate. in addition to reducing the excessive use of meat, phytates, and oxalic acid that is present in spinach, for example, if the diet contains large amount of them. In addition to this, the intake of vitamin D and protein should be adequate, at least meeting the recommended dietary level in general. So the common medications that are used include calcium lactate, in addition to calciferol, which is a vitamin D analog that is used with calcium supplement in this condition. Wherefore, the calciferol, it can also be useful to use in these conditions. So diuretics can sometimes be given to prevent too much calcium from being lost through the urine, which is a problem that can lead to kidney stones. So taking diuretics also reduces the amount of calcium and vitamin D supplements that are needed, in addition to overusing of steroids that can cause hypocalcemia. Therefore, it should be carefully monitored. And for herbs and potential supplements, it shouldn't be used without discussing it first with the physician to avoid any medication interaction. And for the nutrition education and care management, we should indicate which foods are good sources of calcium, phosphorus, as well as vitamin D. Also, we should indicate which food are sources of phytate and should be avoided. And if the dietary intake is a concern, therefore, these should be immediately explained to the patient. Also, we should discuss the role of sunlight exposure in vitamin D deficiency and how it can relate to the individual needs of the patient. And for home tube feeding, if it was used, we should teach the patient on appropriate sanitation processes and food handling procedures. And for the hyperthyroidism, parathyroidism, and hypercalcemia. First of all, the primary parathyroidism results from parathyroid adenomas in up to 80% of the cases, and hyperplasia of the parathyroid gland in about 10 to 20% of the cases or cancer cases. So double parathyroid adenomas occurs in about 2 to 15% of the cases, and the parahyperthyroidism has been associated with premature death in CVDs and should therefore be quickly managed in these cases. Also, in cases of secondary hyperparathyroidism, it occurs in renal failure or even after renal transplantation. So, calcitriol deficiency and phosphorus retention are involved in the pathogenesis of this condition. And parathyroid gland and hyperplasia develop in the oozomatic patient, therefore producing hyperglycemia and hyperphosphatemia. So, in the cases of secondary hyperparathyroidism in chronic kidney disease that is stimulated by dietary phosphate loading and ameliorated by the dietary phosphate restriction. So the disorder is considered to be complex in that not enough phosphate is cleared from the body, but phosphate is released from the bone and vitamin D is not produced. So thereafter, the absorption of calcium in the gut is low and the serum level of the calcium are even lower. So in children with renal failure, growth can be impaired, and postmenopausal women after having gastric bypass can show evidence of secondary hyperparathyroidism with elevated bone resorption. So there is an effect of early breast tumors on the calcium homeostasis. Subclinical hyperparathyroidism can also increase the risk of breast cancer. So age-induced increased parathyroid hormone plasma level have been associated with cognitive decline as well as dementia. So having increased parathyroid hormone levels may become a biological marker of both dementia and osteoporosis. So the parathyroidectomy can induce a long-lasting improvement in the regulation of blood pressure and the left ventricular diastolic function, in addition to other signs of myocardial ischemia with improved life expectancy. So a minimally invasive procedure is available for this condition, as well as after the surgery, mild cognitive changes seem to improve, especially for depression and anxiety. And for the intervention objective, we should lower the elevated serum calcium and the urinary calcium levels, maintain the calcium level between 8.4 and 9.5, as well as normalizing the serum phosphate and keeping the phosphorus between 3.5 and 5.5. So the elevated constipation, anorexia, weight loss, and weakness can resolve after improving this medication or vitamin intake. Also, avoiding any clinical consequences such as renal osteodystrophy, hyperphosphatemia, cardiovascular calcification, and extraskeletal calcification with endocrine disturbance and neurobehavioral changes. Also, we should prevent rickets and growth delay in children and prepare them for surgery if the parathyroidectomy is necessary. So for food and nutrition, we should use a low calcium diet with fewer dairy products, including nuts, salmon, peanut butter, and green leafy vegetables. Also, extra fluid is useful to protect or even prevent dehydration, which can elevate the serum calcium level. Also, we should limit the phosphorus containing food if hyperphosphatemia is present. In addition, using alternatives such as non-dairy creamer, sorbet, or jams with white rice, noodles, and multigrains should be recommended if the patient want to have extra calories. Also, dietary protein for balanced intake of protein in adults should be recommended and ensure that the patient takes the required amount. Some of the common medication include vitamin D therapy that sends a signal to the parathyroid gland to slow down the making of the parathyroid hormone. So this can help to prevent many of the unwanted complications of hyperparathyroidism. Also, using phosphorus-rich food is recommended, and this is a list that we can use to help us to determine the intake of phosphorus in general. So some of the common medication include the treatment with active vitamin D from analogs can increase the VDR expression, in addition to inhibiting the growth of the parathyroid tumors and reducing the parathyroid hormone levels. Also, having CINSPR has been approved to treat SHBT in renal patients, and phosphate binding agent that doesn't contain calcium can offer a therapeutic alternative for managing renal osteodystrophy in these patients. In addition, once yearly intramuscular calcium injection have been used to correct vitamin D deficiency. Also, controlled trials are needed to determine the effect on the parathyroid hormone level over time. Also, some antacids can contain high levels of calcium, therefore should be monitored carefully. And having biphosphonate can be needed to decrease the risk of osteoporosis. And for herbs, using conjugated linoleic acid can reduce the prostaglandin E2 synthesis, which is required for parathyroid hormone release. But more research is needed in this area to ensure the best outcome for the patient. And for the nutrition counseling, we should discuss foods that are sources of calcium, phosphorus, and vitamin D, in addition to indicating the food sources of phytate and oxalate if the intake is concerned. In addition, we should discuss the role of sunlight exposure in vitamin D formulation and how it relates to the individual needs. And most importantly, we should instruct the patient to drink plenty of liquids in order to be hydrated at all times. And in renal patient, we should focus the counseling that may help to clarify any misleading or misunderstanding of simple dietary facts that the patient need to follow. In addition, the doctor should monitor calcium and potassium levels monthly and even quarterly after stabilization. In addition to this, exercise and smoking cessation may be needed in these patients. And if the patient is using home tube feeding, then we should ensure appropriate sanitation processes education. And for the metabolic syndrome, it is defined as insulin resistance syndrome or syndrome X. It has a simultaneous clustering of the low levels of HDL cholesterol, in addition to hyperglycemia, high waist circumference, hypertension, and elevated triglyceride levels. So, any three of the following 5 criteria constitute the diagnosis of metabolic syndrome. So, these can include elevated waist circumference, as well as elevated triglyceride level or reduced HDL level, or even having treatment for low HDL cholesterol level, as well as elevated blood pressure and elevated fasting glucose. So it is associated with CVD and often lead to type 2 diabetes. And this condition affects some young people, but usually affects those aged more than 55 years of age. And increased birth weight, excessive energy intake, physical inactivity, obesity, and smoking with inflammation and hypertension can all contribute to the development of metabolic syndrome. So individuals who are obese and insulin resistant are particularly prone to this syndrome, and having an apple-shaped figure is riskier because the fat cells that are located in the abdomen release fat into the blood more easily than the fat cells that are found elsewhere. So the serum adipocyte levels are associated with insulin sensitivity, and they are decreased in type 2 diabetes and obesity. So genetic and environmental factors can contribute to the risk, and the initial insult in the adipose inflammation and insulin resistance is perpetuated through chemokine secretion, adipose retention of the macrophage, and elaboration of pro-inflammatory adipocytokines. So in women, depressive symptoms are associated with metabolic syndrome, especially with the elevated afternoon and evening cortisol levels. So management of metabolic syndrome should focus on lifestyle modification, especially reducing the caloric intake and increasing physical activity. Also, phytochemicals, monounsaturated fat, antioxidant foods, spices such as turmeric, cumin, and cinnamons have anti-inflammatory effects. And the intake of whole milk, yogurt, calcium, and magnesium will protect against metabolic syndrome, whereas the intake of cheese and low-fat milk and phosphorus doesn't. So reducing the inflammatory state should be a primary objective of our intervention and the insulin resistance that are caused by adipose tissue. Also improving the body weight, reducing the abdominal obesity in particular, with having a realistic goal for weight reduction. Also promoting physical activity and recommendation should include practical, regular, and moderate regimen of exercise. In addition, achieving and maintaining cholesterol and blood glucose level with blood pressure that are indicated by the American Heart Association should be followed. In specific, for the atherogenic dyslipidemia, for the elevated LDL cholesterol, we should give priority to the reduction of LDL over any other lipid parameter. Also, achieving LDL cholesterol goal based on the patient risk category is recommended. And these different goals are as the following, depending on the risk of these factors. And for the atherogenic dyslipidemias, the triglyceride level should also be controlled. And if the HDL cholesterol is less than 40 or less than 50 in women, then a raised HDL cholesterol to the extent possible with standard therapies for atherogenic dyslipidemia. And for the elevated blood pressure, reducing blood pressure to at least more than 140 over 90, and reducing it further to the extent possible through dietary life changes. So for the glucose, if the intermittent fasting glucose, then we should delay the progression of type 2 diabetes and encourage weight reduction and increase physical activity. Also in diabetes, for hemoglobin A1C levels that is above 7, we should have lifestyle therapy and pharmacotherapy if necessary, as should be used. And for the prothrombotic status, we should reduce the thrombotic and fibronectin risk factors, as well as lowering the dose of aspirin therapy or the prophylaxis that is recommended. Also, there are no specific therapies beyond lifestyle for the pro-inflammatory status, but antioxidant and omega-3 fatty acid may be helpful in this case. And for food and nutrition, the general recommendation include having low intake of saturated fat, trans fat, and cholesterol. Also increasing the use of omega-3 polyunsaturated fatty acid intake, as well as monounsaturated fatty acid. In addition, we should plan a Mediterranean type of diet using more fiber and starches, especially whole grains and raw fruit and vegetables. And having a plant-based diet can be useful in these cases. In addition, we should plan a a DASH diet containing about 3 to 4 grams of sodium with good sources of potassium, calcium, and magnesium. And monitoring the blood glucose level with carbohydrate restriction as necessary is recommended. In addition, we should encourage the patient to have soy proteins as meat substitute several times a week, as it can be helpful with weight reduction as well as dyslipidemia. In addition to ensuring adequate intake of folate and vitamin B6, 12, C, and E, preferably from food or otherwise from supplement. Also, consuming dark chocolate in small amounts regularly can help to lower blood pressure and improve cholesterol level, with helping with insulin sensitivity. Also, spreading the energy load by eating small, frequent meals is recommended. And having the common medication to lower the lipid, as statin, should be used initially unless it is contraindicated, as well as it can decrease the biomarkers of inflammation and oxidative stress in a dose-related matter. Therefore, this should be monitored closely. And the blood pressure medications can be prescribed, but we should monitor for any necessary restriction of sodium or higher need of potassium. And the medications that diminish the insulin resistance and the dietary altering lipoproteins are necessary. So having low-dose aspirin is not generally a problem, but taking with a meal or light snack to prevent the potential for GI bleed is recommended. And for herbs, having antioxidant supplements are not recommended, but intake of antioxidant-rich food should be suggested. Therefore, trials with alpha tocopherols have been disappointing, but their intake should be within the normal range until further evidence is required. Also, having high serum selenium concentration have been associated with the prevalence of higher FBG and LDL and triglycerides. So further research is needed to determine its role in the development or the progression of metabolic syndrome, while other herbs and potential supplements shouldn't be used without discussing it first with the physician. And for the nutrition counseling, the widespread screening is recommended to slow down the growth of this syndrome. Also, prevention should start in childhood with healthy nutrition and daily physical activity, with annual measurement of weight, height, and blood pressure beginning at 3 years of age. Also, discussing the nutrition of DASH and Mediterranean diet in managing this syndrome is recommended, as well as obesity, that is a major contributor to the problem. Therefore, weight loss can help to improve the health status of this condition. So a diet that is rich in antioxidants and DHAs is beneficial. And finally, the dietary guidelines are consistent with lowering the risk of metabolic syndrome. Also, having regular physical activity can help in lowering the elevated blood cholesterol level and blood pressure. Also, walking or exercise that is pleasant for the individual is the one that is to select. And reducing sedentary lifestyle or activities, including television and computer time, is recommended. And for foodborne illnesses, it should be discussed if the patient is using home tube feeding Therefore, it should be monitored closely. So we have reached the end of our webinar for today. If you have any questions, please send them on the chat so we can discuss them. بالنسبة للي بيستفسر عن ال patient on tube feeding, is there any formula for them? The formula will depend upon the patient lab data or condition. For example, if they had complication of uh, heart failure or renal failure, then we should give them one that is high in calorie and restricted in fluid intake. But otherwise, normal formula with additional calories may be given in some time. So we shouldn't rely on the thyroid status only, but also on the associated complications. الله يعافيكم بالتوفيق جميعا. For the one asking about the role of anti-obesity medication in the reduction of mortality rate in metabolic syndrome, considering that most of the complications that are associated with metabolic syndrome are actually due to obesity. So anti-obesity medication can present a very useful and helpful solution in these patients. تم الانتهاء لليوم. لو ما عندكم أي أسئلة بكده نكون انتهينا.